For our third speaker, I'd like to invite Eula Wang up to the podium. Dr. Wang is an associate professor in emergency medicine and geriatrics and palliative medicine at the Icahn School of Medicine at Mount Sinai in New York. She is also a core investigator at the Geriatrics Research, Education, and Clinical Center at the James J. Peter Bronx Veteran Affairs Medical Center. Her research focuses on improving the quality of care that older adults receive in emergency department settings and ranges from observational studies of analgesic safety and effectiveness in older patients to multi-center implementation science studies of geriatric emergency care interventions. Thanks, Dr. Wang.
Great. Thank you so much for this opportunity. So I'm going to really preface this by saying I'm coming at this from the perspective of an emergency clinician, and also one where I'm going to also bring in the aspects of care for older adults. 10,000 people turn 65 every day, and so this is going to be a growing preponderance and part of our population to pay attention to, especially when we take into considerations opioid guidelines. So because of that fact, I think it's really important. I came from this at the angle of what does it mean to have acute pain? And I'm really thinking again from the perspective of emergency clinicians. So really this is new incident onset pain associated in my perspective of emergent conditions. And so while we think of chronic pain as that being 6 months or greater, I'm not even thinking 6 months or less or even 3 months or less. I'm thinking pain within days or weeks, so very short duration. Most importantly, severity. I'm really thinking about severe pain, maybe moderate to severe, but really severe pain would be an indication. And again, because it's acute, I think it's very important that we realize that this is pain that comes from an etiology that does heal and should resolve for whatever the underlying cause. So when I asked colleagues and I thought about, well, are there any contraindications for using opioids in emergency care? What were there? And I couldn't think of many except for allergies, hypotension, and respiratory depression. I also want to say that when we come from this emergency perspective, we do initially potentially prescribe parenteral medications. So IV, IM, sub-Q, preferably not the latter two, but with the mindset of can we transition them to oral and opioids for potential of discharge. So pain is a very common presentation in the outpatient setting, but even more so in the ED setting. It's a majority of our patients, and their goal is they want their pain relieved. Our goal is to figure out what's going on and to treat that pain. So with that, how do we take into also the considerations for older patients? And I do want to preface here that with older patients, they're going to often have a decrease in opioid requirements because of metabolic changes with their hepatic function, their body fat, their decrease in renal clearance. For these very reasons, they may actually clear and require less opioids. Also remember, they're on many medications. Some of these patients may be on proton pump inhibitors, which will affect the way their GI absorbs medications. And because they're also on other drugs, we have to be very cautious about potential for drug-to-drug interactions. And many of them may actually use over-the-counter medications before they arrive to the ED or when they're seeing you in the office. What about administering opioids in older adults? This is a common mainstay in terms of administering medications in all older patients. So start low, go slow, but really important here is also consider longer dosing intervals. When we're giving these medications in the ED, we're going to reassess them. Maybe a normal patient, we might reassess them every 1 to 2 hours. Older patients, they're going to take a little longer to clear the medications. So it's very important to reassess and titrate and then perhaps give them a little bit longer before we escalate. Again, it's very important that these drugs be administered short-acting, no sustained or extended release drugs, and also short course, very critical for older patients, shorter courses. Side effects are things to take into consideration, I think even more so in older adults. They have the same side effects that younger patients have, but those that I have in asterisks, they're even more severe. So constipation is a common presenting complaint. Delirium, falls, hip fracture, we may be treating their pain for a fracture or musculoskeletal issues, but we may actually, by giving them an opioid, put them at greater risk for developing a fracture. And then finally, overdose. For older patients, a lot of the times we have to realize they may have cognitive impairment, vision impairment. If they have minimal caregiver support, they may not have the ability to see what medications they may or may not be taking, so have a greater risk for opioid overdose. When it comes to substance misuse and addiction, in older patients, they actually have a potentially slightly greater risk for physical dependence, but tolerance and withdrawal is actually less common. When it comes to addiction, they actually have a lower risk than younger patients. But as we're seeing now with our aging baby boomers and perhaps a generational difference or approach in terms of using medications and other substances, we're starting to see potential signal for increasing misuse in this older population. They are at greater risk for depression and social isolation, so may lack social support and turn to these drugs of abuse. And I do want to highlight at this point the opportunity to think about women. Women are preponderance of our aging population, and for disparities in care, they may often be not diagnosed as having risk of addiction, but the prevalence is actually quite high at greater than 10%. So when it comes to the specific medical conditions I'd like for us to consider, my list is actually not different at all from Dr. Serrell's or Dr. Brown. Dental conditions, falls and fractures, tears, non-operative, of course. I do want to highlight here again, falls, fractures, very high risk in older patients. If you meet a person in their 80s, a woman, 1 in 5 of them will have had a hip fracture, and if they're in their 90s, 1 in 2 will have had a hip fracture. And because of this reason, increasing studies are really looking at alternatives to systemic analgesics in older patients. And so femoral or fascia iliaca blocks are actually found to be just as, if not more effective in terms of pain relief and decreased risk of adverse events than when compared to opioids. Abdominal pain, same conditions as we saw earlier, renal colic, biliary colic. I would like to add to this list pancreatitis. We see that more often in the emergent setting. And then finally, sickle cell disease, same thing. When we see them, and by the time they're in the emergency department, we're often going to first line reach for a parenteral opioid, and then consider that. And it's really important here. It's not just the IV fluids and the oxygen treatment, but also really important to treat that pain. Burns and shingles, we're going to see burns in the emergency department, and in this case, I think opioids are actually often indicated because it'll help allow with more pain-free dressing changes and potentially minimize the risk of chronic pain developing down the line. And then finally, I want to take this opportunity just to highlight a couple of indications where really we often see in the emergency department, but really there may be minimal to no evidence of use of opioids. So sciatica, whereby we found analgesics compared to placebo, there were really no significant differences. We see a lot of headache, and in most cases, for almost all those headaches, they can be treated with NSAIDs, acetaminophen, ergots, and triptans. And then finally, lower back pain. We all see that. We see that quite often. Increasingly so, we're realizing that behavioral and non-pharmacological and multimodal therapies are just as, if not more effective. Thank you.